So I'm Jonathan Myers. I'm from Wills Eye Hospital. It's really excellent to have the opportunity to speak with you today about my experiences with Avisi and the VisiPlate. Academy is a great time to catch up with people, great time to see old friends. Appreciate some of my old friends coming out today, and so appreciate everyone's interest in the VisiPlate. So I should note that I work with a number of companies, a number of roles: researcher, advisor, consultant. It's been a privilege to work with Avisi last almost half dozen years or something like that. And I also work with other companies in this space you should be aware of, including Microd and Glaukos. So just so you know where we're going with this, a lot of you are probably familiar with and have performed minimally invasive blip surgery, or MIBS, as opposed to MIGS. And the goal here is to try to get better results for our patients with less duress for ourselves and for our patients. And so I'm going to talk a little bit today, and I've presented with the e-poster the results from a recent trial in South Africa, if you've seen the e-poster at the Academy this weekend, showing that the VisiPlate in this trial really had pretty pronounced pressure reduction. Patients with much lower pressures, less medications, half the patients on no medications, and a low rate of needling, which has been a big issue for some surgeries. So that's where we're going, but let's pull back and talk about the big picture. So the reason that we're all interested in this is because glaucoma is such a big issue. More than 76 million people across the world, more than 4 million in America. Of course, that's just the people we know about. For every patient with glaucoma, there's another patient we don't know about, they don't know about, they're not even being treated. Recently, this morning, Dave Freeman was presenting, and he mentioned that that's 50% for Caucasian patients. For Hispanic and patients of African descent in America, it's probably more like 70% of the people are undiagnosed. So really a huge issue. And it's a huge issue because, of course, glaucoma leads to loss of vision. And visual impairment, loss of vision is actually very common. You can see the numbers there worldwide. In America, at least 200,000 people are legally blind from glaucoma. That's probably a tremendous undercount, actually. It's hard to get hard numbers because a lot of the big databases just have visual acuity data, don't have visual field data, so you lose the constricted field definition of legal blindness. And then the really killer stat for me as a glaucoma specialist is that even with treatment, somewhere between 5 and 25% of patients with current treatments will still become blind in one or both eyes over 20 years of treatment. You can say, well, that's a pretty wide range. Well, there are a bunch of different studies out there, depends on the populations, depends on the definitions. But let's just say there's room for improvement. I think we can all agree on that. Why do people get glaucoma? Why do they get worse? Well, there's a host of risk factors. This is just one of the many great figures out there from many great papers. Factors like the structural issues around the lamina cribrosa, factors like blood flow to the optic nerve, migraines, systemic health issues, metabolic syndrome, just all the things that you can imagine and you guys all know, including, of course, genetic issues. But the one we all love is intraocular pressure, because that's the only known modifiable risk factor for developing glaucoma and for getting worse from glaucoma. And that's why some people call glaucoma the pressure-sensitive optic neuropathy. It's really the only one where lowering pressure makes a big difference. Of course, there are many ways to treat glaucoma: MIGS, laser, surgery, all work. You know, my patients call me a little plumber, and I don't mind because it's true. Problem tends to be outflow, not inflow, but we work at both ends of the problem with our treatments. These are great treatments, but they aren't perfect treatments, or I wouldn't be talking to you today. This slide I make up every hour on the hour because there's always a new MIGS. So if your favorite MIGS is not on this slide, I apologize. I truly do. I love all of these for different patients, for different days, depending on my mood. I have a crazy 8-ball before I walk into the OR that tells me which one to do. But we have outflow things like the iStent and the Hydrus that bypass trabecular meshwork. We have excisional surgeries that remove the trabecular meshwork. We have lasers that can reduce fluid inflow. We can flush Schlemm's canal with different treatments. And then we have things that create new drainage channels. When we look at traditional MIGS, angle-based surgeries, there's really a trade-off between efficacy and safety. And I'd say that's true for the entire glaucoma space in general. But we can all cite exceptions to this, but I think we'll agree that for most of the studies, the pressure reduction tends to get to the mid-teens, 15 to 17. And that's great pressure reduction for many patients, but not good enough pressure reduction for all patients. And that leads us to filtration surgery. Now, I went into practicing glaucoma in the 1990s. That was a little while ago. And at the time, we were doing a lot of trabeculectomy. And we all love trabeculectomy. Well, we all did a lot of trabeculectomy. It works great. In fact, I know of no procedure that's more effective at preventing additional vision loss. But it comes at a cost. It's a complicated surgery, complicated to do, complicated follow-up with complications. And so it's not always loved by patients and doctors. As we've had more alternatives, so many surgeons are finding ways to avoid trabeculectomy, which means they're doing less, which means that it gets more interesting to do a trabeculectomy and it becomes loved less. And it's all understandable. A recent survey paper looked at all the studies that have been published on MIBS. So MIBS creates the opportunity, perhaps, of using technology and innovation in materials to create a better path to filtration surgery, getting the benefit of lower pressures with a more standardized surgery, less dependent on surgeon skill, with greater pressure reduction and a quicker recovery, perhaps. The one that we're most familiar with, at least in America, is of course the Zen 45. It's hard to believe it's been 9 years since this came out. I was an investigator with the Zen back when it was Aquasis, had the opportunity to put in Zen 45 and Zen 63 in Peru. Really interesting. I myself was an early adopter. I found that it did get patients recovered more quickly from surgery. It was a quicker recovery, often better vision more quickly. But I do it less now, and many of my colleagues do it less now because of some of the long-term issues in terms of success. And as a single lumen device, we've seen some sudden failures where a patient who's been 12 for like 2 years on no meds comes in at 30 or 40 with additional field loss. And that's discouraging. The PreserFlow, some of my colleagues in Canada last night were telling me about their experiences with PreserFlow. In the US, it's not yet FDA approved, and I'll talk a little bit about that study that led to the FDA's decision. Both single lumen devices. There are other investigational efforts. We're part of the Zen 63 trial. As I said, I got to do some of these in Peru and found that it was perhaps a more dramatic early pressure reduction than the Zen 45. Calibri, MIMS, and I should note that I'm a consultant to Microt that's done the A-Stream, which is another single lumen filtration device that's been used in Korea. So PreserFlow. You're all, I'm sure, I hope, familiar with this excellent study. They recently published the 2-year results. The FDA trial was really the 1-year results. If I look back and try to say what went wrong with the process of the FDA, I think they just chose 2 good people to do the study. Dr. Moster from my institution, Joe Panarelli, Nanook Katana. These are great glaucoma surgeons, and they got great results. Look at the TRAB results. The average pressure is about 11 throughout the entire study on very few meds. It is tough to compete with that. And you can see that the PreserFlow results in the solid dark line, the pressures were higher in the 14s, and the failure rate was higher than trabeculectomy. So kidding aside, I think the FDA looked at that and said, why doesn't everyone just do trabeculectomy? And I'll say because everyone isn't Joe Panarelli, Marlene Moster, Devinder Grover, Anup Katana, Michael Stiles. These are great people. And not everyone has those people in their office, and that's why I'm so interested in MIBS. When we look at the Zen experience, this is a really nice review article. Carlo Traverso, great guy, a lot of great people, very experienced surgeons on the paper. I should call out Vanessa Vera, who's been very much involved in Zen pretty much since its inception, works for AbbVie, knows tons about it. So looking at this is 2/3 of a table that was too big to put on the slide, but really summarizes the Zen experience. And as you look, you'll see that the average pressure reduction is in this sort of 14 to 16 zone, let's say. So good pressure reduction. And the average needling rate, 20 to 45%. Now there are studies that are a little bit higher or lower for both of those numbers, but I think that gives you the gist of it as you look down the table. That's good pressure reduction, but not quite the 11 of TRAB. Everyone knows this slide. If you've ever seen any glaucoma talk, you've seen this slide. And again, this is ageist, people with field loss who go on to surgery. And in this study, the goal was to get the pressure under 18. And if you got the pressure under 18 all the time, this line, that group of patients on average didn't have additional field loss. 15% got a little worse, 15% a little better, but not much progression. The average, though, of their pressure, to keep the pressure constantly under 18, the average pressure was 12. That wasn't the goal, but it's where they wound up to get under 18. And that has given all of us ideas that we should be shooting lower maybe. And this has led to the development of VisiPlate, a new approach with new materials, new technology. So this looks like a sort of GIF animation, computer generated. It's actually scanning electron microscopy of a 5-micron material that's been stamped into an egg crate shape. So the actual material is 5 microns, egg crate, that whole thing, 20 microns thick. It's a multi-channel device that's been studied in humans, rabbits, other animals, very well tolerated. And the idea is that we have many channels for fluid to go out from the eye and to be absorbed under the conjunctiva. This shows you the shape of the device. It has a neck. The neck's put in the anterior chamber. It has a body that allows absorption of fluid in the subconjunctival space. Picture on the right sort of gives you a sense of that. And it's about 9.5 millimeters long. The neck is about 2.5 millimeters wide, so it's a stab incision to get it in the anterior chamber, and then you lay it under the conjunctiva. So, the meat of the matter. Trial in South Africa with 3 surgeons enrolled 15 patients with open-angle glaucoma, pressures of 18 to 40 on medications. Okay? So the patients with this surgery, I should note, all had injectable mitomycin C. Just good to keep that in mind. It's filtration surgery. About half the patients were women, and the patients were primarily Caucasian with 4 black and 1 not specified. So the baseline pressure, like many studies in this field, about 24 on 2 meds. A little different from many of the studies in this field is the mean deviation was -11. So this is pretty serious glaucoma when you get to mean deviation of -11 for the entire group of patients. And the results, at 1 year, not 3 months, at 1 year, the average pressure was 13.1 on 1.3 meds. And that's a 42% drop. And about half of the patients were on no medication. So really pretty excellent results in my book. Thankfully, there were no serious events. There's no device extrusion, no erosions over the device, no patients with suprachoroidal hemorrhages, no prolonged hypotony, maculopathy, and 2 patients out of 15, that's 13%, underwent bleb needling. So relatively low rate of bleb needling in this group of 15 patients. In terms of visual acuity, 12 of the patients had no vision reduction. 3 patients had a transient vision reduction at 1 month that by month 2 had returned to baseline in all patients. So pretty well tolerated. This gives you an example of one of our patients at a year. And I should mention, you may have questions after this. I know an expert, Dr. Edie Miller-Ellis, who is there for a lot of these patients, and she knows tons about this, so talk with her as well. But this patient has a diffuse bleb. You maybe can see the tip of the device. And what I find fascinating is the anterior segment OCT. So this thin line, that's the VisiPlate. That's going from the anterior chamber, multi-channel, through the corneal scleral stab incision to the subconjunctiva space. It's about the same thickness, I'm not a cornea doc, as Descemet's membrane, right? So super thin. And that gives lots of room to not be near the cornea, not be near the iris. Here are 3 more patients. You can see their pressures, 18 to 36 on meds, and they wind up on no meds with pressures of between 9 and 12. And I'd like to point out these blebs are low and diffuse. They're neither too avascular nor too vascular. They're good-looking blebs. So that's what's got me actually pretty excited about this technology. This shows you the average results pressure-wise for the entire group. So you can see they start at 24, they wind up at a year about 13, but it's a fairly stable line, although early on, 1 day, 1 week, there is some variability, and you can see the medication reduction. So again, this is a ultra-thin, novel device. It's filtration surgery, but a new approach to filtration surgery. Low complications, low needling, and that's why the FDA just approved the Sapphire trial, a phase 3 trial in the US. That will be enrolling patients sometime in the next month or 2 for first patients. So a super exciting time for Avisi. I'm going to be part of the trial, helping to proctor some of the early surgeries since I had the chance to see some of the surgeries in the Dominican Republic. I'd point out that it's tubeless, it's multi-channel, and it has some of the characteristics we're looking for in MIB surgery, a more standardized approach to filtration. If we can achieve these things, lower pressure, greater safety, fewer complications, quicker recovery, I think it will allow us as surgeons and our patients to feel more confident doing surgery earlier. And I'm going to admit, I don't believe glaucoma, when you have field loss, is an eye drop disease. I take it more seriously than eye drops. And I hope that technology is going to bring to our patients the results we need to improve on those vision loss numbers. So that's most of what I have to say about VisiPlate, but I'd welcome questions. I'd welcome Edie's thoughts from her experiences. And I appreciate very much everyone coming out this afternoon, Sunday afternoon at Academy. Sometimes there are a lot of distractions, so thank you.